Okay, so we're going to discuss maybe chronic hamstring case. In the literature for low back, when something goes from acute to chronic, what is that time frame? Is it pain for longer than 6 months? Is that
Um, that's a great question. Uh, gosh, I
I
think
normally think
chronic
it's
might be
not
greater
as
than six months. Yeah, subacute
is
is
it
like 3 months to six
okay.
months, and then chronic is like 6 months or more.
Okay, so the hamstring case that you have is 10 years. So this is so we're
Yeah,
going to
so
discuss it. So we'll discuss a hamstring case and then I'll pass it off to you.
yeah, well, interestingly enough, it's not at this point in time, it's not a hamstring case. And so
Oh,
that
okay.
I think that's sort of the impetus for this discussion and kind of going through how we establish point A in this case and how that allows us to kind of see what might be missing from a point B perspective. That's the whole purpose of this case. We've obviously already discussed hamstring injuries and hamstring rehabilitation previously on Absolute in our written work. We have the hamstring program now for sale for those that may be interested. That kind of takes you through like a three-phase progression on an actual hamstring injury. This case, was maybe a hamstring injury at some point, but is currently not. So to start it all off, um, it's interesting because I tend to get, these at least one of these clients weekly. And so the first thing that this client said, this is a female, extremely active pre-pregnancy, um, had a child 18 months ago, um, is now, starting to ramp up activities again, to her previous levels. So she's a runner, she's a swimmer, she strength trains a few times a week. She's just really, really fit and active. Um, anyway, the first thing she said to me was, I've been everywhere. You're the last possible person that I could see regarding this injury. And I do kind of get that a lot. So I tend not to see things that are super acute. I tend to see things that are uh, a little bit longer or long-standing. So there are more pieces of the puzzle to kind of put together in that way. So um, that kind of shapes the process of kind of how we have to establish point A, because point A in an acute injury is pretty straightforward as long as you understand injury mechanisms and some biomechanics and some physiology and some healing, healing times and so on and so forth. The acute injury point A is actually quite simple. It gets a little bit more difficult with longer standing things and with more information to gather. So, client shows up, says, I've had 10 years of proximal hamstring tendinopathy. Um, I've had periods of no discomfort. I've had periods where I've been able to train uh, relatively pain-free, but for the most part, for the last 10 years, and now, and sorry, so like a pretty active pregnancy, and now getting back up into higher activity, the hamstring discomfort is coming back. Uh, Imaging that was a couple years old, showing so ultrasound, which showed some tendinopathic changes in the proximal hamstring, MRI, which showed some signal in the proximal hamstring. I didn't actually see the images. I didn't see the reports. I'm just going on what the patient or what the client told me. I will seek those reports just to try to see what the detail is on them. Because again, you never know. Sometimes clients giving you reports or the information on reports is like broken telephone. So who knows? But the imaging did show some proximal hamstring stuff. Um, Currently is bothersome with running, obviously, which is a activity that she would like to be able to do at a higher level than she currently is. Bothersome playing with her child, who is now, relatively young and active, so running around, picking up the child. Even simple things like lifting groceries or heavy things from the floor seems to be bothersome in the hamstring. Um, and when I say bothersome, she does describe some pain associated. She feels some pulling sensation in the hamstring, although not always in the proximal portion of the hamstring. So generally, let's just call it backside of the thigh. She does feel some pulling. Um, has had everything. So name a intervention that a therapist would do, and she's had it at some point. Shockwave therapy, laser therapy, cupping, acupuncture, instrument assisted soft tissue therapy. Recently, now getting back into trying to get back into a higher level of performance. She has received some injections from the sports medicine physician. I'll come back to that in a second. Has seen numerous practitioners with some change, but never any real, true, long-lasting change. And I think that's sort of how I want to sort of spin this discussion is again, I'm in a I think in an advantageous position because I can see, or in cases like this, we can see what has been done before, and oftentimes I try to do the exact opposite
Hmm.
because you know what I'm saying? Like, why if someone's coming to us and they're in a situation like this, I want to know every detail about what has been done up to this point for a few reasons. Number one, right off the bat, I'm not going to do those same similar things. Number two, I want to get an idea of what was done, how long it was done for, what that may have provided the client. Because, maybe there are some similarities of some things that I might do where she says, or he or she says, yeah, with eccentrics, I found a lot of benefit. Okay, well, maybe we can add some eccentric training. Most importantly, though, the more information that you can gather about previous treatment plans is you can see what has been relatively untrained. And I think that's the most important thing in these cases is to try to see where the focus has been and maybe what has been missing. I want to come back. Stop me at any time if there's more detail that you
Well,
want. I'm
I want
trying
to
to
just
kind
say,
of just glance through this.
yeah, so you're discussing treatment training history point A, because in the module, we've discussed training history point A, but you're discussing treatment history point A as the
Yes.
intake.
Yes. So I'll kind of break that down as well. But I do want to come back. Okay, yeah. So let me break that down now. So obviously pa- this is a pretty detailed intake because there's lots of components of point A. Like I said, somebody comes in and says, I'm in excruciating discomfort in my lower back. I can't do this, that, or the other. I mean, realistically, at that point in time, you're taking a health history.
Hmm.
You know what I'm saying? It's pretty
Hmm.
focused. In cases like this, you're taking a health history, but your health history now is a 10-year health history,
Hmm.
right? You're also weaving in, because she's highly athletic, you're weaving in a performance history. Okay, you're a runner. Give me, in the last 10 years, when was the time that you ran relatively pain-free? What was associated with that? What was your how did you feel? so on and so forth, because you need to get the idea of where performance has been okay, where it has, been decline, where it's declined in that time frame. Associated with that would be the training history, right? Because if you're going to take a performance history, you need to know the training history. So at those times when performance was high, what were you doing? At
Hmm.
times
Hmm.
when performance was a little bit lower, what were you doing, and maybe what were you not doing? And you know what I'm saying?
Hmm.
So, in addition to that, there's some imaging history here that we kind of need to go through as well. So there's lots of things that kind of formulate, and in this case, what would eventually establish point A, but they're all kind of like bucketed pieces of information that we as practitioners and we as programmers are eventually going to have to link together to figure out how we're going to create the strategy moving forward. Um, so there was lots of different pieces of information that ultimately we have to get on paper. And as we're going through it, we're starting to, as we're taking this information in, and me personally, you're starting to make these links in your head. So as I'm taking this information down, I often just draw lines. This piece of information links to that. This piece of information links to that. Kind of like a matching exercise, just so you can kind of go back and see. And then I'll write down where that might lead us going into the strategy. So, so let me kind of walk through that. So, first things first, chronic hamstring problem. Well, 10 years duration. Hopefully, there's a piece, an area in our brain that says that doesn't really make sense. Okay. Like, it's not that it's not entirely possible, but 10 years of the same proximal hamstring tendon being problematic seems improbable in the scale of probability. Okay.
Hmm.
So first thing I wrote down as we're going through the health history, I wrote down, it's in my paper, which I unfortunately don't have in front of me, is this truly a hamstring problem? Question mark.
Hmm.
Right? Because you're starting to go through this and you're like, well, this isn't consistent with what I would think to be a true hamstring issue. Okay. Again, starting to go through some more information now on the health history. Uh, Feels like certain movements need to be avoided, feels like certain training needs to be avoided, has not done certain movements and certain training to this point. So then you start, I actually wrote down on the piece of paper, I wrote neural net question mark. Has this neural net been stimulated? Again, these are all just, this is the way that I do it. Just kind of, these are pieces of information that I'm trying to make linkages to. Going through let's call it the rehabilitation history, which we'll call the training history. Um,
Hmm.
So lots of eccentrics, lots of concentric work, lots of focus on hip stability, core stability. Um, so a lot of very specific work, I would call it. So a lot of, let's say, let's give the benefit of the doubt to all those practitioners, a lot of very anatomically based rehabilitation. Okay.
Hmm.
A lot of biomechanically based rehabilitation. Oh, you know, so she kind of was going through some of this. Like one practitioner was testing her one leg balance and her foot function. It was a little bit different than on the other side. So they did a lot of balance training and a lot of general what we'll call proprioceptive work. All great, but again, very specific to those things. Okay, so
Hmm.
it's it again. I'm kind of taking all this information in again. and I'm trying to think about where a lot of the focus has been over the last 10 years. I will say more specifically, probably the last half decade is where she's really tried to ramp up training and just can't. So, a lot of hamstring specific stuff, a lot of like glute, medius, minimus, hip stabilizer stuff, some core training, and some general um, what I would call flexibility training. So some yoga has been thrown in there, some Pilates has been thrown in there. This is a client that also was a previous gymnast in her younger years. So um, so so again, you can kind of hopefully uh, as I go through this, we can kind of see like the areas that have been focused on. So in our learning module in point A, one of the things that we talk about in one of the point A videos is we have to kind of see from above all like the things that have been relatively trained, but we also have to understand the things that have been relatively untrained. And when you put that in the ecological framework, you can kind of see here there has been some pretty good biological training. It might not have been, exactly how we would have done it. It might not have been the most effective way to do it, but at least the practitioners to this point were saying, okay, well, the biology needs to be changed. What you can also see is that what has been relatively untrained is the nervous system and the ecology of the neural net. And one of the things that we've really tried to establish at Absolute is that the neural net kind of governs everything, right?
Hmm.
So even though we do have biology and we do have neurology, and each one has their specific means and methods to be trained, ultimately you do have to create a linkage between them because
Hmm.
the neural net has to output in the biology and the biology has to feed back to the neural net. And so at some point, whether that is through, skill training or practice or, you know, sport specific things, you are ultimately going to have to link them. So in this case, there has been a pretty good fill of the anatomical or biological bucket. There hasn't really been a lot in the neurological bucket, and there hasn't really been a lot of linking the two together. It's
Hmm.
being, hey, I don't feel discomfort. Okay, I'm going to go right back into training. Hey, I
Hmm.
don't feel discomfort. I'm going to go right back into training. And there hasn't been enough linkage created between those two ecologies. At least this is what is coming out in the way that I've sort of established point A at this point in time. Does that make
Hmm.
sense?
Yeah, 100%.
Okay.
Hmm.
So, so physical examination, which is the last part of point A. Obviously, we use the FRA at Absolute, amongst other things, but specifically in this case, and any clinical case for me personally, it's always an FRA. So some of the findings on FRA were very eye-opening as well. So again, oh, I should go back. I should go back. One of the things that she also um, had a complaint of was that sometimes she feels some stiffness and overworking of her hip flexor, which again makes sense. It's kind of the opposite side of the hamstring, so maybe there is some relationship there. In addition, she feels like when she does train, because she is in the gym a few times a week, that uh, any real deep hip flexion causes some feeling of a pinching sensation in that side. Okay. So
Hmm.
I should have actually said that because that is an important piece of information. So now we have to establish our physical exam. So we have to establish our FRA. Well, the first thing that we need to make sure that we consider is joint function because anytime we have that closing side restriction, limitation, whether or not it's associated with pain, we have to get an idea about the joint. So we have to understand about the joint. Obviously, we have to understand about the linear movements of the hip, considering that this is a hamstring issue. We have to understand the tissues and what the tissues are telling us. And within that realm of tissues, we need to know what the biological components of the tissues are telling us in terms of, are we able to establish length? What does that feel like? Uh, is it being limited by anything? And we also have to establish within the tissues what the nervous system is understanding about those tissues. Is it going to be shielding those tissues at any level? So there's a few things that we have to kind of establish on our FRA. So I'm just going to kind of go through the findings. I'll share the findings, and then we can kind of put them together to help us establish, the strategy or the initial strategy. So this is a left hamstring issue, so left hip. Internal rotation, passive to active ratio, completely normal. As a matter of fact, it was like large. So like 40 degrees of internal rotation.
Hmm.
Achieves that pretty easily actively as well, at least getting that minimum 85%. External rotation passively, um, adequate. Again, if you kind of pushed it a little bit further, and when I say adequate, we were getting to 45 degrees. Any further,
Hmm.
and you do start to see some compensatory motion through the pelvis, but enough in terms of what I thought she needed for what she was doing. A little active discrepancy there. And when I say active discrepancy, not necessarily that she couldn't achieve close to that 80 to 85% ratio. Um, she was just having to kind of pull in the pelvis and the lower back to do so.
Hmm.
So, a little bit of lateral flexion, a little bit of tilting the pelvis. So you can see that maybe there is a little bit of a coupling issue between the hip and the pelvis. Nothing crazy, um, better than most. Bent knee hip flexion, we do start to get a limitation in that only because of that closing angle um, restriction. No real pain though, just kind of feels like it hits a little bit of a barrier. Ask the client, what do you feel? Yeah, I feel that kind of in my hip. So there's a little feedback loop for us right off the bat. And that highlights now that external rotation finding a little bit more, right?
Hmm.
In that, what I thought was initially maybe enough external rotation isn't enough external rotation. The
Hmm.
ability
Hmm.
to actively move into external rotation, which comes with a lot of that tilting of the spine and pelvis, now gets highlighted even more. Because, like I said, when I passively did it, I could get to a range. And then when I moved more, I saw the same compensation passively. So that highlights now, right? That
Hmm.
highlights and
Hmm.
says, well, first and foremost, we have to create a little bit more space in that hip from an external rotation perspective.
Hmm. Hmm.
Okay. So that kind of goes into our notes. That has to be part of the strategy initially. Everything related to the tissue of the hamstring, everything related to bent knee, hip flexion, any isometric loading of the hamstring, any concentric loading of the hamstring, any eccentric loading of the hamstring. And I didn't do any crazy hard eccentrics, but like partner assisted, like again, she's kind of on her back, like this, and I'm kind of pushing up and I'm saying, okay, go ahead and resist me as I push you up at this rate. Let's go a little bit faster. Go ahead and resist me. Let's go a little bit faster. Go ahead and resist me. No issue in the hamstring. So, long story short, there was no uh, tissue assessment findings. There was no examination findings. There were no general strength findings, either isometrically through length at different periods of